When a shocking event happens, everyone rushes for a simple answer. Was it schizophrenia, or was it substances? Here is the thing, those two can overlap so much that arguing over the label distracts us from the real clinical questions.
Tonight, we're going to break it down carefully. There will be no armchair diagnosing and no sensationalizing. We'll stick to timelines, clinical definitions, and what professionals actually look for. First, some quick ground rules. We're talking about publicly reported information and general psychology education. We are not diagnosing anyone on the internet. A real diagnosis requires a full evaluation, access to records, and time. Also, keep in mind that headlines and criminal charges are not the same thing as clinical truth.
We can explore possibilities without pretending we're holding someone's medical chart. Let's start with the big question: schizophrenia versus substance or medication-induced psychosis.
This latter category is what most people mean when they say drug-induced schizophrenia. And yes, people say that all the time. But clinically, it's usually framed as substance-induced psychotic disorder.
This is because schizophrenia is a specific, long-term diagnosis, while substance-induced psychosis describes psychotic symptoms that pop up in connection with substance use, intoxication, withdrawal, or even certain medications.
So, what are the basics of schizophrenia?
What are we even talking about?
Schizophrenia is a psychotic disorder that can involve hallucinations.
Like hearing or seeing things that aren't there, and delusions, which are fixed false beliefs.
It can also include disorganized speech or behavior and often causes changes in motivation, emotional expression, and overall functioning over time.
And here's where people get stuck. Psychosis can look very similar across different causes. The brain only has so many ways to flash a check engine light.
Now let's talk about the age factor because I know that's on everyone's mind.
The person in question might be 32, and people often say, doesn't schizophrenia usually show up in the early 20s?
Often, yes, especially for men, but it's not a strict rule. The typical age range for diagnosis can extend into the early 30s.
And here's another important point. The timing of symptom onset is not the same as the timing of diagnosis.
Someone can show subtle signs for years before they ever get a formal diagnosis.
Exactly. You can see a long lead-up phase where their functioning changes. They might withdraw socially. Their performance at work or school might decline. They could become more suspicious, or their sleep and thinking patterns might change, all before any obvious break with reality. So if we're asking, does 32 fit for schizophrenia? The answer is, it can, depending on the timeline.
The real question becomes, what's the pattern across the years? Now let's tackle the other side, substance or medication-induced psychosis. This is when hallucinations or delusions develop during or soon after substance intoxication or withdrawal, or after exposure to a medication known to trigger psychotic symptoms. And here's the key clinical issue: timing and persistence. Clinicians look at a few things. Did the symptoms begin during heavy use, intoxication, or withdrawal? Do the symptoms fade as the substance clears from the body and the system stabilizes? Or do the symptoms persist well beyond that substance window? Because if the psychosis continues long after stopping the substance, clinicians start to wonder, is this a primary psychotic disorder, or did the substance just unmask an underlying vulnerability?
That unmasking concept is huge. Some people have risk factors like genetic vulnerability, developmental stress, trauma, or sleep disruption.
Then a substance can act like lighter fluid on a spark. And let's bust a myth. Substance-related psychosis doesn't always vanish overnight.
Depending on the substance, especially stimulants, it can last for days or even weeks.
So thinking, it didn't go away fast, therefore it must be schizophrenia, isn't a safe conclusion.
Right. There are no shortcuts.
So how do clinicians try to tell the difference?
Think of it like a structured detective board, only with fewer red strings and a lot more paperwork.
Here's a practical comparison checklist. First, timeline. If symptoms clearly start during heavy use, intoxication, withdrawal, or medication changes, substance-induced psychosis climbs to the top of the list.
If symptoms appear during a period of sustained sobriety, or clearly predate any substance use, that leans more toward a primary psychotic disorder.
Second, the pattern over time.
Schizophrenia often has a pattern of a longer-term decline in functioning, changes in cognition, and a persistent vulnerability to relapse.
Substance-induced psychosis, on the other hand, may track more tightly with the substance use pattern, worsening with use and improving with abstinence, though it can still be complicated.
Third, negative symptoms. Schizophrenia often includes what we call negative symptoms, like reduced emotional expression, a lack of motivation, and social disengagement.
These can persist even when someone isn't actively hallucinating. Substance-induced psychosis can definitely bring on agitation, paranoia, hallucinations, and delusions, but these symptoms tend to be less stable over time.
Though again, not always.
Fourth, psychosis outside of substance windows. If there are episodes of psychosis when someone is not using and not in withdrawal, that's a significant clue.
But to be fair, you'd need reliable information to confirm that, like toxicology reports, collateral information from family and friends, medical records, and direct clinical observation.
Now let's get to the part that is uncomfortable but important. The label, always the headline-grabbing answer people want.
Because from the outside, psychosis can just look like psychosis. Someone can look high and actually be in a primary psychotic episode.
Someone can look schizophrenic, but really be intoxicated, withdrawing, severely sleep-deprived, or reacting to medications.
Public perception is not a diagnostic tool.
Exactly. And if a person has both a severe substance use history and a history of psychotic symptoms, then the honest answer is that the differential diagnosis can be very messy.
Clinicians often have to treat what is right in front of them. First stabilize the acute episode, and then clarify the diagnosis over time.
Which brings us to a great point. Does the label even matter if they retreated pretty much the same?
In the acute moment, when someone is actively psychotic, distressed, and possibly unsafe, the early steps can overlap a lot. These include ensuring safety and providing supervision, evaluating for underlying medical causes, stabilizing symptoms, and often using antipsychotic medication.
In other words, if someone is hearing voices and is paranoid to the point of being a danger, clinicians don't pause and say,
"Wait, before we help, let's argue about which category you belong in."
yes. Stabilize first, label later, and do it carefully.
But the label can matter in the long game. If it's schizophrenia, long-term planning may involve ongoing psychiatric care, relapse prevention strategies, consistent medication management where appropriate, and therapy to build insight, coping skills, and functioning. It would also include family education and support, as well as vocational and social rehabilitation services.
If it's substance-induced psychosis, long-term planning still involves mental health care, but it heavily emphasizes substance use disorder treatment, relapse prevention, and recovery supports. It would focus on addressing triggers, trauma, and any co-occurring disorders, and monitoring whether psychotic symptoms re-emerge with abstinence or under stress.
And sometimes, the most accurate answer is that both are true. Substance use can worsen psychosis, and psychosis can drive substance use.
People may try to self-medicate their terror, their insomnia, or their inner chaos,
until it becomes a second crisis layered on top of the first. Co-occurring disorders are extremely common, and they complicate everything. Medication adherence, insight, stability, relationships, housing, employment, you name it.
Now let's revisit that onset question in plain language. Schizophrenia often shows up in the late teens through the 20s, especially in men.
But a diagnosis can occur later, and symptoms can exist long before the official label is applied. So the key question isn't, is 32 too old?
The key questions are, what does the timeline show? Was there a gradual change? Were there earlier warning signs? Were there breaks from reality during sobriety? Were there lapses in medication? Was there escalating substance use? Were there significant stressors and sleep disruption?
Yes, and sleep disruption alone can be like gasoline on a fire. Severe insomnia can intensify paranoia, distort perception, and destabilize someone who is already vulnerable.
And that's why clinicians will ask about everything: sleep, substances, trauma history, medical conditions, medication changes, family history, prior hospitalizations, prior functioning, and collateral information from people who knew the person over time.
Here's the most important takeaway. Whether psychosis is primary schizophrenia, substance-induced, or a mixture of both, it is not a moral failing.
It's not evil.
It's not weakness.
It is a serious mental health crisis that requires serious care.
Especially when there's a risk to self or others.
The internet loves certainty. But mental illness often lives in the world of probabilities, patterns, and clinical caution.
So if you're re-watching this and you're retrying to reduce a complex clinical picture to a single word, just pause.
Because the responsible stance is this: we can discuss the science of schizophrenia, the science of substance-induced psychosis, and how clinicians tell them apart, without pretending we know what we do not know.
And if you or someone you love is experiencing hallucinations, delusions, severe paranoia, or if you're worried about safety, please seek professional help immediately.
In the US, you can call or text 988 for crisis support.
Take care of your brain, because it is the only organ that can convince itself it doesn't need help. Which is honestly a little dramatic of it.
The brain might say, "I'm fine," while also setting off every alarm in the building. And that's the point. We have to take the alarm seriously, no matter what label ends up on the chart. Thanks for watching.